Welcome to the Berkeley Research Group ThinkSet podcast. I'm your host, Eddie Newland. Berkeley Research Group is a leading global strategic advisory and expert consulting firm, providing independent advice and dispute consulting around the world to corporations, law firms, government agencies, and financial institutions. For more, please visit thinkbrg.com. On today's episode of the ThinkSet podcast, we speak with BRG Managing Director Brian Hoyt. Brian's consulting career spans more than 20 years and is focused on the healthcare industry, one of the most important parts of the economy and one that continues to quickly evolve. Brian has worked with health insurers, managed care companies, and pharmacy benefit managers, leveraging analytics to digest relevant information and provide sound, data-based advice. Today we'll chat about the complex world of provider directories and the issues they present for healthcare plans. Based upon his experience as both a trusted advisor and expert witness, Brian will discuss the financial, regulatory, and legal environment healthcare plans face today. And with that, let's get started. Brian, thank you very much for joining us on the ThinkSet podcast today. How are you?
Doing great. How are you?
I'm doing real well. So you've written a lot about provider directories. Can you broadly define what they are?
Yeah, I think at the most basic level, a provider directory can be thought of as just simply a listing of doctors. There's lots of doctor listings out there. If you look on the internet, there's directories that are maintained by hospitals if you want to find out what provider is actually working at a certain hospital. But then there's also the provider directories that are maintained and required to be maintained by health plans. The health plan provider directories are those, basically a listing of those providers that participate with that health plan, so that are in network with that health plan. So to the extent that a health plan has various health insurance products that they offer, they're required to list the providers that are actually in network with each of those health insurance products. Kind of the evolution of provider directories over the years, back in the day, if you wanted to find out what provider was in network or accepting your health insurance, you would look on the back of your health insurance card and actually make a call to the provider or to the health insurer to find out if a particular provider was in network. That then kind of became a very voluminous, hard copy listing of providers. So if you wanted to find, if your provider was participating with your health insurer, you would page through this document to find your doctor's name. And since that time, they've evolved into online web tools, which a health insurer like Aetna or Humana, they're required to have an online provider directory that's easily accessible and that's searchable. So if you want to go on and find your provider, you would enter your zip code, enter the specialty that you're interested in visiting, and run a search to find out what the participating providers are. Interestingly enough, in spite of the requirement for the online provider directory, a lot of the federal government and a lot of states actually still require health insurers to provide the tome of the hard copy provider directory upon request.
Yeah, I actually recently had a specialist that I had to go see for, shall we say, a sports injury for somebody that shouldn't still be playing sports. And I got the hard copy version that was nice. I was able to circle it in the office with the doctor as he ran through the different folks. And then I went home and did exactly what you were talking about, search based on where the office is located, because I want to make it convenient as I can for myself, and then compare and contrast that list of the recommended in-network versus what was close to the office.
Another caveat to that is that even with the online provider directory, you'll still find a lot of insurers kind of give the disclaimer down at the bottom. And this is not a criticism by any means, but it's just a way. The disclaimer basically says you still should call that provider before you go see that provider, to make sure that they accept your insurance.
Yeah, and I imagine that's got to be knowing a little bit of what goes into the background of compiling databases. If you're talking about doctors, not only countrywide, but sometimes internationally for different health plans. That must be a struggle for the health plans themselves to maintain an accurate directory for people to reference.
Absolutely. When I started working with plans on health directories, provider directories a few years ago, I didn't have nearly the level of understanding about them at that point that I do now, just simply because I was thinking, web-based provider directory seems easy enough. It's a list of doctors and you get the information from your network of doctors, and you basically just put that information into a web tool on your provider directory. But what I've come to find out, having worked with numerous plans on this issue, and with regulators as well, is that this is really hard. It's not an easy thing. And I think if you talk to anybody at any plan, you'll get the same answer from them. And that is that this is not an easy thing. To put an accurate list of providers up on a website is difficult. And the thought of actually trying to keep the website up to date is difficult enough. But then if you then think about, well, how do we keep a hard copy printout of a list of doctors up to date as well? The way that this information is changing almost on a minute by minute basis. I mean, if you think about the size of these provider networks and so forth, and the number of data elements that could possibly change for any given provider, and then multiply that by a network of 100,000 doctors or something. If you think about that in a hard copy context, that directory is going to be out of date as soon as it comes off the printer, as soon as it finishes printing. So I think that's one of the big difficulties with these provider directories, is just kind of that dynamic nature of the information that's contained therein. So an example of that would be provider phone number or provider address. So to the extent that you have a provider that is perhaps credentialed in multiple specialties, or, is practicing in various locations, and perhaps this provider is at location 1 on Monday and Tuesday, and then he's at location 2 on Wednesday, and then location 3 on Thursday and Friday. Anytime any one piece of information at any of those locations changes, that needs to flow through to the directory. And to the extent that the provider is the one that has the best information or the best knowledge of when those things change, it's then a matter of that provider providing the information to the health plan so that it can be propagated to the website or to the hard copy printout. And that's a difficult process. And I think that's one of the big reasons that plans struggle with this, is not only the dynamic nature, but then also getting the information in a timely manner from the provider whenever that information changes. Another big aspect, and I think this is a related point, is that there's a required data element on these provider directories that all of the federal healthcare programs, it's required in all of these programs, and it's required by states as well. And that is whether the provider is accepting new patients or not. And sometimes it's phrased differently. Sometimes they say provider is accepting new patients, or it has to say the provider is not accepting new patients. But either way, they expect it to be kind of a binary choice, a yes or a no. But the difficulty is that it's not a yes or no answer. I mean, there are times when a provider may be accepting new patients, but not in every case, right? They may be only accepting certain types of patients or certain conditions, or there's a lot of variability or a lot of variables that could go into whether providers accepting new patients or not. And anytime that yes or no changes, depending on what that provider chooses to pass along, that has to be updated as well.
Yeah, I mean, obviously a lot of information that needs to be tracked and in some way needs to be provided access to on the consumer end. Can we look a little bit at the stakes for all of this, like some of the ramifications, other than obviously just violating some of the federal statutes that you talked about, and I'm sure there are state ones as well, but what are the consequences for the health plans themselves, or even for the consumers, if these directories fall short?
Yeah, I think from the consumer aspect first, it's an access issue, right? And the regulators are very much starting to recognize it as such. To the extent that a health plan, would have a provider listed in their provider directory, that the presence of that provider in the directory would seem to indicate that that provider is in network, and say perhaps they're accepting new patients. But if you look on the provider directory, you find the contact information for that provider, assuming that the phone number is correct and you actually get to talk to somebody on the other end of the phone to make an appointment. You make your appointment, you show up on the day of the appointment, and assuming that the provider location and address is correct in the directory, you successfully get to that provider. And then you get to the front desk of that provider and you give them your insurance card, and they look at it and they say, oh, we don't accept this insurance. So you can imagine having gone through all that trouble, that's very frustrating for a consumer. And from a user experience, that's not ideal. So to the extent that the information in a directory is not preventing, but perhaps making it more difficult for consumers to access care, that's what the regulators are really starting to care about. If you get to the point where you're actually seeing a doctor, and sometimes this happens more in the emergency room context, and where you don't necessarily have the option of giving them your insurance card and finding out if they're in network or not. But perhaps you receive services from what appeared to be an in-network hospital, but then you end up getting what they're starting to refer to as a surprise bill for out-of-network charges from providers that were ancillary providers that were actually practicing in that in-network hospital, but they themselves were out of network, right? And this is an area that states are starting to crack down on. From the plan perspective, there's a lot of risks. The plans are the ones that are CMS, Centers for Medicare and Medicaid Services, they regulate the plans because they can, right? They have the statutory and regulatory authority to do so. So they have the ability to, depending on the severity and the nature of the discrepancies or errors that are found in provider directories, they have the ability to sanction a plan, right? To prevent, if it's a Medicare Advantage organization, for example, and they start to find a lot of errors in provider directories, they can do what they call enrollment sanctions, right? So that they can prevent you from enrolling new members. They can also assess civil monetary penalties. And these are penalties that are assessed typically by deficiency and then multiplied by per affected enrollee. So if you think about perhaps a Medicare Advantage plan that has tens of thousands or hundreds of thousands of enrollees, and CMS comes in and says, well, we think that this deficiency in your provider directory impacted 50,000 enrollees, we're going to multiply your civil monetary penalty by the number of enrollees. So those penalties start at, I think, $10,000, and some are $25,000, and then they assess them per day and per enrollee. So these are real numbers that can add up very quickly. So that's kind of the financial risk to the plan, and also a regulatory risk. But then there's a litigation risk, right? And what we've seen in this area with provider directories, the pattern has become typically there's some kind of enforcement action. Enrollees, consumers complain to either a consumer health organization or to a regulator or to an enforcement agency like the Attorney General's office. And they start to complain in insufficient enough numbers, saying that this plan is horrible, their provider directory is inaccurate, we can't get to see our doctor, so on and so forth. That happens enough, and these enforcement agencies start to crack down and assess these fines and try to remedy this issue. But then after doing that, you have class actions that are sure to follow after the plan. This is what we saw in the state of California, where there was a lot of activity, regulator activity by Department of Managed Healthcare against several plans, two of which, got hit very hard with sanctions and penalties. And then there was a series of class actions that followed that were very, very costly for these plans. Not only did they have to comply with the terms of the settlement from the regulator, but then they also had to pay restitution. They had to pay the difference between what these patients would have paid in network versus out of network. This has ended up costing these plans in California literally tens of millions of dollars.
So extremely high stakes, to say the least.
Yeah.
I know some of the rules also say that provider directories must be, quote, easily accessible. Though when you talk about the litigation, I imagine that becomes a bit ambiguous of what that exactly means and where you fall short of that standard. Have there been any rulings or decisions around what that, quote, easily accessible would mean when they're putting these things together?
This is one of those cases where the regulators, and this is actually defined in the guidance from CMS, and I'll read this. It says, the general public is able to view all of the current providers for a plan in a provider directory on the issuer's public website through a clearly identifiable link or tab, and without creating or accessing an account or entering a policy number. So that's what CMS has defined as being easily accessible. Now, I think if you start to look at that, there is some subjectivity around the words that they used, but I think at the end of the day, the intent is a good one in the sense that they want to make sure that consumers can find these provider directories easily and that they're not cumbersome in terms of having to create an account or, go through and enter my email address and, I'm going to get marketing emails now as a result of having done this. They want to make it as easy as possible for the consumer to find that provider. To me, this is kind of a scratching the surface of getting access to care. I think this issue is much more complex than just having a find doctor link on your health plan website.
You talked about how in California in particular, there was a high level of enforcement, and then that led to a lot of litigation. But across the board, how different are rules at the state and federal levels, and how does that further complicate things for health plans looking to operate in certain states?
Yeah, I mean, the rules are different, not only at the federal level across different federal healthcare programs, but then states are regulated or insurance is regulated at the state level. So, to the extent that a particular Department of Insurance wants to regulate something more heavily and more stringently than and define standards that are more stringent than those that are defined at the federal level, it's perfectly within their realm to do so. And several states have actually done that. On the federal level, if we think about the federal programs that really are impacted by this, managed Medicaid, Medicare Advantage, and QHPs or qualified health plans that are sold on the exchange, there is a good amount of overlap in the requirements there. And I'm thinking here around the data elements, just the information that's required to be displayed in the provider directory, although there is some variability around it in terms of what they call things and what it actually looks like on the website. Interestingly, QHPs, the guidance there does not actually require provider name. It's not one of the required data elements that's listed in the guidance or in the reg. So, of course, they intended for the health plan to display the provider name, because otherwise, then how would you search for a doctor? But I think there are some differences just at the very superficial level in terms of the data elements that are supposed to be displayed. But then if you also look at, there's not only kind of what we'll call the content, right? The data element aspect of it, the information that has to be displayed. But there's also various other processes that are defined, again, federal and state level that health plans have to comply with in terms of how up to date they need to keep their directory, how often they need to verify the information that's contained therein. And again, even at the federal level, there's some variability around those requirements. For example, in Medicare Advantage, there's a requirement in the guidance that Medicare Advantage organizations have to reach out to their provider network on at least a quarterly basis, right? So what that means is that you as a Medicare Advantage organization, you need to develop a pattern and practice and a process around reaching out to all of your provider networks that are assigned to your Medicare Advantage plans and verify the information for all those providers on at least a quarterly basis. That's a big requirement. But if we look at QHPs, there's no defined requirement, right, in terms of how often or whether the QHP has to actually do provider outreach. Similarly, there's another requirement around the QHPs were kind of the pioneer. CMS said that not only did the QHPs have to make their provider directory available online, but then they also had to make the directory available in what they called a machine readable format. And when this first appeared in the guidance, I think it was 2015, they didn't define exactly what machine readable was. So what we've seen is that kind of has evolved over time, and now there's some agreement on what that machine readable file looks like. And then for the other federal healthcare programs, Medicare Advantage, by contrast, they tend to think of machine readable. It's not required, but it's kind of a best practice, and it's what they call appropriate. So while it's not required, they're kind of leaning very heavily towards having plans actually make it available in a machine readable format. And I think just as a final note on the federal side, a couple of years ago in the guidance, they wanted to align all these requirements. And there was, you could see it in the guidance, and this was kind of where CMS was headed. They were definitely trying to align all these different requirements so that it would make it easier for participants in federal healthcare programs, carriers, health insurers that were participating in, perhaps they had plans in all three programs. CMS wanted to make it easier, so they started to align these requirements. And in the recent guidance, 2017, 2018, going into 2019, we've seen kind of, some of that pull back a little bit. And then, the current administration is more prone to defer things to the states. We see this on the network adequacy side. And also there's some pushing the provider directory aspect down to the state as well. Now, on the state side, there's a lot of variability around, on the states. And there are some states that are very active in terms of defining requirements that are more stringent, that go over and above those that are required in the federal healthcare programs. California is leading the charge. Like I said earlier, there was a lot of regulator activity, Department of Managed Healthcare, against several plans in California, two big ones in particular. And that not only led to the litigation, but it also led to the introduction of a bill, Senate Bill 137, in the California legislature, and it's now law. This actually defines requirements that are, in a lot of ways, more stringent than the federal requirements. One very interesting thing about the Senate bill in California was The early draft of that bill, the early language of that bill contained an accuracy standard by which all health plans had to comply. So the bill, starts going through different versions, markup, what have you. The final passage of that bill did not contain an accuracy standard at all. And I think that alone speaks volumes around how complex this process is and how difficult this is for plans. Because, if you talk to anybody that kind of works in provider directories or understands the issue, they're going to say, what is the comparison to accuracy? There's the phrase, the single source of truth, that kind of gets thrown around in directory circles that I tend to run in. And it's a matter of, if you're going to have an accuracy standard, you have to have, something to compare it to. And, doing secret shopper polling and stuff that CMS and other regulators want to do, that's one way to do it. But does that really get to the right answer? And is there really any scalable way to measure accuracy in a real time and ongoing basis? That's the challenge.
To look a little bit forward, what do you think the future holds for these directories?
Succinctly, I think it holds more regulator activity, more enforcement activity by the regulators, more litigation, because I think that not only has this issue caught the attention of regulators and plaintiffs' attorneys, the issue of network adequacy is kind of joined at the hip with provider directories. And just real quick for the audience, network adequacy is the requirements around, for each health insurer, they have to, again, this is defined by statute and so forth, they have to establish a network of providers that is sufficient in both number and type of provider to adequately serve the enrolled population within a certain service area. Now, there's a lot of very subjective terms in that, but there are some quantitative standards that have been defined for certain programs and also by certain states that plans have to comply with. To the extent that the provider directory is kind of the most, you can really think of it as like the most public-facing representation of a provider network. The health insurer puts their provider directory out there. It says, this is our network of providers. This is where you should search for a provider. And to the extent that they are putting providers in that directory that turn out to be not in network, then what a lot of the class actions that are being filed right now, there's the plan in Washington right now that's currently before the court. And what they're saying is that is a fictitious representation of your provider network. If you have providers that are erroneously listed in that directory, what they're saying is that that's not accurately reflecting your provider network. And to the extent that there are providers listed there that are in fact out of network, the question then becomes, and all, a lot of these complaints are saying this provider network is not adequate, right? So they're making this allegation of inadequacy, not only inaccuracy on the provider directory side, but then on the provider network side, it's an inadequate network to adequately serve that population. So I think we're going to continue to see states defining requirements. There's a lot of activities in states right now. In California, not only do they have the Senate bill, but they're undertaking a very noble effort to actually develop a statewide provider directory utility. And interestingly, one of the plans, Blue Shield of California, that was hit very heavily by the regulator fines and litigation in California, they're throwing down $50 million for the provider directory utility. And it's a staggering sum, but it also speaks to the severity and the seriousness of this issue. Plans are taking it seriously. They want to get this information right. They're doing everything that's within their power to do so. But regulators are interested too. Regulators, I think they have good intentions. As CMS says, they want to provide access to care, and to do that, they need accurate information. Now, the litigation side, I think those that are bringing these complaints or these suits, they clearly want to do right by their class, that they've assembled for the action. But so I think we'll probably see more activity on all fronts.
Well, Brian, thank you so much for joining us today on the ThinkSet podcast. We'll look forward to catching up with you again soon.
Sounds good. Thanks for having me.
This ThinkSet podcast is brought to you by the Berkeley Research Group. You can subscribe to the podcast and access other content from ThinkSet Magazine by going to thinksetmag.com. I'm Eddie Newland, and thanks for listening. The views and opinions expressed in this podcast are those of the participants and do not necessarily reflect the opinions, position, or policy of Berkeley Research Group or its other employees and affiliates.